Bismillah ar-Rahman ar-Rahim. So today's topic is traumatic brain injury and how we can diagnose it and what will be the prognosis. So we start here, and I have Dr. Dushad online. So let's start. So basically, last time what I taught was about traumatic and non-traumatic brain injuries, and now today, so the non-traumatic brain injury we talked about last time, and uh, and today our topic will be the acquired brain injury, like the traumatic. So the non-traumatic we talked about was it could be due to stroke, near drowning, aneurysms, tumor, infectious diseases that affects the brain, and lack of oxygen supply to the brain. Now the traumatic means that there is a trauma to the brain. So there could be falls, autocatalysis, assaults, motor vehicle accidents, and industrial accidents, sports injuries. So the trauma could be that something hits the brain or the brain hits something. These are the two mechanisms. The third mechanism is that the brain oscillates between the two walls of the skulls, and acceleration, deceleration, injury repeated. So, epidemiology is that each year 1.4 million people present to the UK emergency services, 200,000 are admitted to the hospital, and 40,000 of those have a significant injury, such as skull fracture or brain damage, etc. So, the psychiatric patients have poorer prognosis, and similarly, people who are prone to substance misuse in the past, they have a poor prognosis. And psychiatric practitioners often asked to assess patients with head injury. So because when they come to us, we have to assess the kind of severity and the neurocognitive effects. So collateral history is so important for premorbid functioning. So the a good collateral history you take, it will be good to determine the premorbid functioning. Then, so the epidemiology in the United States is also very similar to the UK. Now, the symptoms of head injury. So you can see it on the screen, but I will formulate it in form of a mnemonic. So it could be headache, altered mental state, and amnesia, and nausea, vomiting. So handle brush is the mnemonic. So headache, altered mental state, and amnesia, like confusion, and then N for nausea and vomiting, D for diplopia, L for loss of consciousness, I for eyes and ear bruising and bleeding from eyes and ears, bloods from ear and nose, the same thing. So, and then runny nose or ear, and then unequal pupils, seizures, and hemiparesis and other focal neurological deficits. And the more these symptoms are there, and more kind of focal symptoms are there, more severe is the injury. So the assessment, how to assess that. So we need to aim to establish the following, uh, like that how severe is the injury in the very beginning. So significant transfer of energy to the head. So something is striking the head. So how strong is that stimulus? Or if the head is striking something, like a wall or a floor, so how strong is that? So the signs or symptoms, are they consistent with the acute head injury? Do they need a CT head? Do they need to go to the A&E? Should the emergency services be called? Are there any other injuries? And then you immobilize the person. So the presence of risk factors for bleeding. So more there's a bleeding, more likely it is that it will be a severe, moderate to severe head injury or traumatic brain injury. So if the Glasgow coma scale in the beginning is less than 13, or it starts dropping 2 hours after injury, then there are chances that there could be a subacute subdural hematoma developing slowly and gradually. And if there is an open injury already, then it is possible that like it could be an open or depressed skull fracture, basal skull fracture, or if there are seizures you're seeing, or focal neurological deficit is very evident, that means that there could be a bleed inside or outside or anywhere between the skull and the brain. And if there are more than one episodes of vomiting post head injury, then there is a likelihood that there could be a bleeding. So it is important to take a very good and careful history, and then you evaluate all the symptoms. You also go for the medications, and note if there are any anticoagulants, and also note down the past medical history. Now, the types of intracranial hemorrhages, it could be extradural. So it will be concave from outside or convex from inside. Similarly, subdural will be opposite. So it will be concave from inside or convex from outside. So the same, it will subdural will follow the same brain curve, while the extradural will be opposite to the brain curve usually. And then there could be subarachnoid, intraparenchymal, or intraventricular hemorrhage. So these are the subtypes. And then what is important for psychiatrists is this classification, which is called the Dodds classification or Department of Defense classification. So whether the TBI is mild or moderate or severe. So if the neuroimaging is normal, if the loss of consciousness is less than 30 minutes, if there is a less than 24 hours of alternation of consciousness or mental state, if there is a less than 24 hours of post-traumatic amnesia, and if the Glasgow coma scale is good between 13 and 15, then it's a likelihood that it's a mild injury. So the loss of consciousness, complete loss of consciousness, that's must be less than 30 minutes. If it is prolonged, then it is going something wrong, moderate to severe. Similarly, the confusion in a mild head injury should resolve within 24 hours. And so post-traumatic amnesia should also be follow the same pattern, that along the confusion, that it should resolve within 24 hours, and the Glasgow coma scale score will be 13 to 15. Now in the moderate, what would happen is the moderate TBI, the normal or abnormal. So the neuroimaging may be normal or abnormal. In the mild, it was normal, but in moderate, it will be normal or abnormal. The loss of consciousness was on less than 30 minutes. Now in moderate, uh, in TBI, it will be more than 30 minutes, but less than 24 hours. So the complete loss of consciousness. Similarly, the confusion may last even beyond 24 hours. And the post traumatic amnesia should also last more than 24 hours, up to 7 days. and GCS will be somewhere between 9 and 12. Now, if the TBI or the head injury is very severe, what will be the outcome? So it could be a normal or abnormal neuroimaging. Loss of consciousness may be more than 24 hours, and PTA could be more than 7 days. Glasgow Coma Scale score may be 3 to 8. So more, kind of, the loss of consciousness is even more than a day, and the post-traumatic amnesia is more than 7 days, and the altered confusion is more than I mean, if the loss of consciousness is more than 24 hours, then of course the confusion is obviously more than 24 hours, because more severe thing is happening, so it's more than confusion. And the GCS is between 3 to 8. So these are the indicators: mild, moderate, or severe TBI, and that's what a psychiatrist should know. So, what other things is that even mild traumatic brain injury can be quite significant. For example, mild trauma again occurring again and again to to the brain. For example, in boxers, so it's mild, but it's again and again, and it may have a serious outcome. So even the mild trauma should be avoided, because if it is again and again, it can be dangerous. Severe injury, possible coma, and even it can lead to death. And clinicians involved are neurosurgeons, neurophysicians, neurologists, psychiatrists, psychologists, occupational therapists, rehabilitation specialists. Comorbidities, the psychological comorbidities, which may not be directly due to the injury, may be post traumatic stress disorder and depression. Now, the international classification, we have already gone through the DOT classification, so or the DOT criteria. So the other things are DSM-5 and ICD-10 and 11. So all these classifications will either classify it as a mild cognitive impairment or mild neurocognitive disorder, or if it is more severe, then it will be classified as a moderate to severe cognitive impairment, or if it is progressive, then dementia due to the injury of head. That's a new term in ICD-11. Or it could be dementia, dementia and other specified disease in ICD-10. So in DSM-5, it will be mild neurocognitive disorder, or it could be a major neurocognitive disorder due to TBI. And organic sequelae can be there. The person may have hallucinations, organic hallucinosis, catatonic disorder, or organic schizophrenia like psychotic disorder or delusional disorder, organic mood disorder, organic dissociative disorder, organic labile disorder, organic PD or personality disorder, mild cognitive disorder, post-encephalitic syndrome, post-concussion syndrome, prolonged delirium, personality change, frontal lobe syndrome, or dementia, or amnesic syndrome, just like the Korsakoff syndrome, or any other specified mental disorders due to brain. Clinical features we have already gone through, that there could be headache, loss of consciousness, and uh, and then nosebleed, and runny nose, or diplopia, nausea, vomiting, unequal pupil, seizures, or focal deficits, hemiparesis, etc. So these will be the clinical features. But if we go into the detail of neurocognitive disorders, so the detail will be, it will be kind of frontal lobish symptoms may be there, impairment in speed of information processing, complex attention, impairment in executive abilities and learning and memory, and disturbances in social cognition may be observed. So all these kind of things which are seen in cognitive impairment and dementia. The A's, so aphasia, apraxia, agnosia, amnesia, apraxia, aphasia. So all these things can happen. So aphasia, visual spatial neglect, constructional dyspraxia. So more the severe and more these A's can be there. Headache can be there, cognitive fatigue, sensitivity to light, noise, insomnia, other sleep disturbances, drowsiness, dizziness, nausea, vomiting, visual problems, neurological abnormalities, seizures and balance problems, and personality change, and emotional disturbance and amotivation. So, some of these symptoms can come under post concussion syndrome, such as dizziness, fatigue, irritability, headache, difficulty in concentration. So, some anxiety symptoms, some cognitive symptoms, and some biological symptoms such as insomnia, uh, and increased take of alcohol, so emotional excitement. If all these things are combined, they can be called as post concussion syndrome. Now it is more classified as a mild neurocognitive disorder. Differential diagnosis. So sometimes the severity of neurocognitive symptoms may appear to be inconsistent with the severity of the TBI. So, sometimes, if the person is already on a substance, alcoholic, then the TBI will be more. Even the mild TBI can result into severe symptoms, or sometimes if the person is well built, so the moderate to severe TBI can be like reversible to some extent. And the other disorders may be PTSD, depression, substance use disorders, and sometimes, occasionally or rarely, factitious disorder. So, the etiology, as we discussed, is that either the brain is colliding with the uh, brain is colliding with the hard surface, or there is a hard thing or stimulus or speedy thing which is colliding to the brain, or brain is colliding with the skull, or it could be a to and fro movement between the skull on an ongoing basis. Uh, uh, so so there can be petechial hemorrhages, cerebral contusions, axonal injuries. So if and sometimes there can be both. So if something hits directly to the brain, or brain hits something directly, so at the site of impact, it is called coup injury, and the opposite side then strikes the skull wall of the opposite side, and that is called counter-coup injury. So there can be a hemorrhage seen at both sides, and then there could be to and fro movement causing acceleration and deceleration injury. So if a person falls, in that case, the the person is hitting the ground, and there can be coup and counter coup both injuries. Or if somebody is shot with a bullet, so the bullet may produce the same coup or counter coup injury, or the road traffic accident may also produce the same. Now, the etiology, so the external forces, explosions, blasts, shearing, and rotational forces may also result in neuronal damage. Microvascular changes can be observed, and intracranial hemorrhages can happen, or any brain structure can be involved, especially the frontal lobe damage, frontal lobe dysfunction. So, if the frontal lobe is involved, then it can cause huge dysfunction. And if it is only, if there are only kind of prefrontal changes, then there will be more of a behavioral changes. And if the whole frontal lobe is involved, then depending on the area. There could be focal kind of symptoms, hemiparesis or sensory damage, etc. So, specific cognitive deficits and symptoms may suggest the areas of damage. CT head and MRI, they are important. Neuropsychological testing over in the long run, and EEG for seizures and slow wave activity. Course and prognosis. So the severity rating of the TBI is one of the factors. If it is mild, then good prognosis; severe, bad prognosis. But as I said, if the mild can have uh, um, a kind of bad prognosis as well, especially if there is an if the person is older age, or there is a history of brain injuries in the past, if there is a history of psychiatric problems or substance misuse in the past. And then mild traumatic brain injury or concussion. So these can cause permanent or long-term damages. Psychiatric symptoms may be depression, irritability, and sleep disturbances. And older individuals are more prone. And then course and prognosis. So moderate and severe TBIs, of course, their prognosis will be much bad, and they will have more kind of symptoms of post and like the post concussion syndrome. And uh, and in children, if it happens in the children, there can be a delay in milestones and an acquired intellectual disability. And sometimes it can result in Alzheimer's disease or chronic traumatic encephalopathy, like long lasting delirium, or alcohol related dementia, or dementia otherwise due to the traumatic brain injury. So the treatment of psychosocial sequelae. So the two modalities are there. We can either try pharmacology, or we can try non-pharmacological modalities. Cognitive rehabilitation, uh, for kind of attention, concentration, interpersonal skills, relationship skills. It can be provided by OTs and psychologists. And progressive physical exercise may also be beneficial in addition. And stimulants, for example, methylphenidate or amantadine, can be given to improve the processing speed or arousal levels or attention and memory. Analgesia, and then treatment for other medical symptoms and seizures can be provided. For moderate to severe TBI, we can provide donepezil treatment. And for treatment of comorbidities such as depression, mood stabilizers and antidepressants, etc., can be considered. Standard pharmacological and behavioral treatments can be tried to treat like organic depression, organic bipolar affective disorder, or organic psychosis if need arises. Beta blockers can be given for agitation, sertraline for depression, and then other modalities of non-pharmacological treatment for moderate to severe cognitive impairment and associated behavioral problems. So aromatherapy, snooze gland validation, music therapy, therapeutic touch, melatonin, and occasionally the antipsychotics, but try to avoid because they increase the risk of stroke in people with already having cognitive deficits. So psychosocial interventions, the other may be self-management, relaxation, etc. And uh, it is important to see the caregiver's burden and to address that. And also the peer support group for patients and families of TBI or cardiac arrest survivors, that can be important. Cognitive rehabilitation is usually done by occupational therapists or psychologists. And uh, and their focus is attention, memory, and executive functioning, etc., to improve that. And fatigue management is another thing which is provided either as a part of the cognitive rehabilitation or separately. And then so treatment of pain, sleep and mood disturbances, education, cognitive behavioral intervention, they can all be part of cognitive rehab. Mindfulness can be tried, working memory training, physical exercise and medications. So this is all about today. So any questions, Dr. Dushad?
No, sir. Thank you very much for your comprehensive presentation. Very, very thank you.
Thank you.